So we shall go on to our last speaker, Dr. Poornachandra, who's a visual retina consultant from Narayan Nethralaya, Bangalore, and he's going to be talking on managing macular hold with retinal detachment. So it's getting more and more complex. So on to you, Dr. Poornachandra.
So good evening, ma'am. Hope you can see my presentation in full screen mode, and am I audible?
Not full screen. Yeah, full screen.
Okay, so thank you so much, Dr. Ashray and Chitra ma'am and I Foundation team for giving me this opportunity. So I'll be talking on managing macular hole with retinal detachment. So we all know the definition of full thickness macular hole. I won't go into the details of it. So macular holes are rarely reported as an additional feature in macula of rhegmatogenous retinal detachment, along with a peripheral causative break. The coexisting macular hole is seen approximately in 1 to 4% cases of this rhegmatogenous detachment. If you look at the publications in 90s, it is less because maybe the OCT was not that extensively used. Now we are using more and more OCT. Maybe we are able to pick up more and more macular holes in rhegmatogenous detachments. So art is almost exclusively on macular holes in eye myopia, about which we have had an extensive discussion. I won't go into the details of it. And we also know the cause for macular hole associated RD in myopic eyes, tangential traction, hardening of the internal limiting membrane, stiffened arterioles, vertical traction by the retina that cannot stretch after staphylomatous elongation. All these things have been extensively discussed. So these are the basic investigations what we do when we decide to operate any RD case. But since if there is an associated macular hole, we should, as discussed earlier, we need to pay more attention to the fundus autofluorescence. Octa, if there is an associated CNVM, it's difficult to pick up in these cases in myopic, but we can definitely try doing it. So there are multiple options which are available for surgical management of macular hole RD. We can do only pneumatic retinopexy. We can do macular buckling. Just now we had a talk from Dr. Barbalina madam. So we can do a pars plana vitrectomy with scleral buckle and a long-standing gas tamponade, vitrectomy with PPV with ILM peeling, with or without oil. So let me show a case example. So this was a 33-year-old male who came with complaints of sudden decrease in vision in the right eye, and the vision was county finger close to face. He had a RD which looked like a rhegmatogenous retinal detachment with an inferior pigmentary changes, but you are not able to locate any of the break. So we did B scan and other things to rule out the exudative, because of course it didn't look like an exudative RD. So, but nothing was suggestive of an exudative RD. We presume this has to be an rhegmatogenous component, but you're not able to locate the hole. Intraoperatively, when I did the core vitrectomy and drained the SRF, this is what I found. This is an intraoperative picture. There is a macular hole with a pear-shaped extension on either side. I'm not sure whether we can call it as a macular break. Okay, so in this case, we decided to proceed with the belt buckle vitrectomy with ILM peeling and the other allied procedures. So this is the video I started with doing 360-degree belt buckle. So this using belt buckle in this particular case is arguable. The reason why I decided to put 360-degree 240 band is first of all, I was not sure of the brake position, where it was. It could be a pars plana brake also. And also this being a phakic patient, I thought it's better to give an adequate vitreous base support. That's the reason I decided to put a 360-degree 240 band. So after that, I'll just go to the vitrectomy part of it. So once I did the place the 360 band, the 240 number band and 360-degree, I cleared the core vitreous. As you can see, once I clear all the core vitreous and the peripheral vitreous, the macular break was visible. So I stained using brilliant blue under the saline. So after that, what I did was I peeled the ILM all over. I peeled it 360-degree around this macular break, and I tried inverting the same ILM onto the hole. So this is the situation which I was telling earlier, where the ILM sometimes can go more than 80% deep. So like that. But this is the kind of hole which I had never seen. And first time I was operating, I was not sure. I thought better to be on the safer side. I peeled it from all over and I just inverted onto it. So after that, I used a silicone oil tamponade because I created a separate drainage retinotomy. So this is the post-operative picture where you can see the retina is nicely attached with a good buccal indent and the macular hole also appeared closed. So this is the post-operative OCT picture after 5 days. 2 weeks and 1 month, though the macular hole, which looked like a break, which is very large, it was nicely closed. But if you look at the outer retina, ellipsoid zone was not still joining. Maybe that interlimiting membrane is interfering with the regrowth or joining of the ellipsoid zone, but the patient had a good visual recovery of 6 by 24 parts. The second case here is a 54-year-old male who came with complaints of decrease in vision. If you see, he had a macular hole, which can be seen here, along with a primary break superiorly. But if you look at the configuration of the retinal detachment, it was not very typical of a regmatogenous. If you look at, there is a demarcation line and there is a peripheral attached retina. So I feel along with the primary breaks, macular hole is also contributing to this configuration of retinal detachment. So this is the OCT of the same patient, which confirmed it was a full thickness macular hole. So in the surgery, I did the same technique which I showed in the last case. I peeled it all over in the 360-degree. I inverted the ILM flaps over the macular region. I didn't try to stuff it very deep because I don't wanted this ILM flap to go subretinal. I just placed it over. When I did the fluid exchange, luckily it didn't displace, and post-operatively the retina was attached, and this is the primary break which has been lasered, and the macular hole was also closed. So this is the post-operative OCT picture where we can see a closed macular hole, vision improved to 6 by 18. Again, as we was discussing, so if you see the outer retina, there is some amount of hyperreflectivity which is seen just above the RPE. I'm not sure. I'm just still following up this case, whether this will disappear or eventually the ILM will join. I am not sure about that. This could be a scarring or this could be the ILM which is folded because we have inverted in a detached retina. So sometimes it can be difficult to peel the ILM in a detached retina because peeling under the PFCL can be challenging if the ILM fragments or if it's abnormally other end. When I was going through this thing, I came across this small marble technique by Dr. Chirag, who practices in US. In these techniques, we introduce a very small bubble of PFCL, which is approximately 1 to 2 disc diameter, not a large PFCL bubble, and we peel around this PFCL bubble and invert it. So while injecting the PFCL bubble, we should make sure that we inject it over the disc and also we'll remove from the disc in order to prevent subretinal migration. So the inverted flap technique definitely reduces the frequency of postoperative flat open appearance of the macular. I'm talking all this in the context of regmatogenous RD, not the myopic RD. That's a different thing. And there'll definitely be improved anatomical outcome of vitrectomy for large macular hole. And also it is hypothesized that, as I was telling, the inverted ILM flap technique induces proliferation of glial cells that eventually fill the macular hole. And also it kind of creates a closed environment for the macular hole wound to heal and opposed to each other. But contrary to the expectation, this technique may not always improve postoperative visual acuity beyond certain extent. The reason could be the potential damage to the retinal pigment epithelium, which is usually less in a case of detached retina as compared to an inverted flap, which we do in attached retina for a macular hole, isolated macular hole. So, and could be a surgical trauma, cytotoxicity of the dyes, and also the ILM tissue which gets introduced and which reaches up to the RP, it may again interfere with the regeneration of the outer retina. The prognostic factor, we know, like we have discussed extensively on the status, duration, extent, all these things matters. So if you go to the literature, the vitrectomy alone, the success rate will be 33%. If we add an ILM peeling, the success rate goes up to 91%. With inverted flap, it is up to 96 to 100%.
Doctor,
And
one
if
minute
it's
left.
combined, Yes, I'm almost done. Vitrectomy combined with scleral buckling, it is 87% for the settling of the retinal detachment, but 31% for the macular hole closure. Whereas PPV with an inverted flap, which I used in my series, I've used the same technique for almost more than 10 cases now. The reattachment is 98 to 100% in my cases. Luckily, so far it's 100%. So, although to date we know that there is no general consensus and controversy remains the most appropriate surgical treatment, but vitrectomy with various additional types of internal limiting membrane peeling techniques like inverted have generally been considered preferred surgical approach in recent years. So, thank you so much.
Thank you.
I'll be happy to take questions.
Thank you, Dr. Poorna, for keeping it very interesting in spite of being the last speaker. So, Ashley.
Sir, Dr. Sarvanan, I'll just ask one question to you and then Poorna. Sir, is there any location you would choose to take the graft, sir?
So because I'm doing a large relaxing retinectomy from the whole 180-degree, you can take it from anywhere you want. I usually would do at the edge of, usually inferior is more convenient to me. That's why.
Okay, sir. But as you go periphery, that
retina will be thinner.
So does it make any difference, or it is just?
I don't think so. I don't think so.
So, Poorna, like under silicone oil, the macular pigments do dissolve. Do you have? So the visual outcome will definitely be lesser in because of the pathology also. But is there any alternative to bypass this? Have you tried under gas?
No, I have tried under the gas. I have showed the case where you have put the silicone. Here I have put the silicone oil not for the macular hole purpose. That's for the RD purpose, for different purpose because travel and all that. This is not for a long-term tamponade of the macular hole. I have tried with the gas with the same results, similar results. Okay, so as I told the first case, I wasn't sure of the thing and patient had to travel back and all that. I don't want to put it under the air for sure. So considering those reasons, I had to put a silicone oil in these two cases, which I showed. But in other cases, I don't use silicone oil in all cases. I just use C3F8, not SF6, C3F8. I want a little longer tamponade. Yeah.
So I think we had a long day, mesmerizing talks from our international faculty. So if we can all agree, we can call it a day.
I think
Thank you so much.
A very, very special thanks to the star-studded expert panel and the kind of vibrant discussions which came up. If an anterior segment surgeon could enjoy all 3 hours of it, I know each of you would have really learned or gained a lot more from the discussions which came through. I would really want to thank each and every one of you, dear expert panel and speakers, for making it such an amazing 3-hour event. Thanks a lot, Ashrey, for literally planning every tiny bit of this meeting. And I think this is what you had imagined or visualized a couple of months back. And I'm sure you must be feeling very happy about it all. I think finally, we all have to thank all our attendees who have watched. And the good news is even if many do not watch today, they do watch over a period of time. Do tell all your friends to watch this amazing retina webinar which we've had today. Thank you very much. Thank you, one and all of you.